Okay, hello again. My name is Brianna Cheslon. Today is May 16th of 2020. I'm going to first preface this video with the fact that my dog is next to me. She has been clingy today, and I'm sorry in advance if she makes any noises. So I'm going to be going over case number 2 and 3. So just a little bit of what case number 2 is about. It says a 4-day-old infant, patient A, is being followed in your clinic. Her birth weight was 5.9 pounds and the pregnancy and birth were normal. Results from newborn screening demonstrated a phenylalanine level of 6.6. A presumptive diagnosis of phenylketonuria was made and additional samples were obtained for further analysis. The parents deny a family history of PKU. So there's like 3 questions in here pertaining to this information that we have to answer. It's as a consequence of this presentation, which amino acid may become essential. The next one is, what are the potential causes of the presentation of phenylketonuria? And the last question for case number 2 is, how would you summarize the results of this test for patient A and patient B? And it shows an increase on patient A in time and a decrease in patient B. So let me get started with case number 2. In phenylketonuria, there is a deficiency of the gene coding for phenylalanine hydroxylase. So tyrosine is not produced. So tyrosine is actually what becomes essential. The phenylalanine cannot be metabolized in the body, so it builds up in the brain, leading to symptoms like failure to thrive, short stature, and mental retardation. Another cause is deficiency of tyrosine, which is essential for the synthesis of thyroid hormones, melanin, etc. So in patient A, the blood level of phenylalanine is not decreased, it actually increased, but in patient B, it decreased on loading of BH4. So in patient B, BH4 deficiency, while patient A has phenylalanine hydroxylase deficiency. And phenylketonuria is a congenital chill of the metabolism that is due to the absence of the enzyme phenylalanine hydroxylase, which makes the inability to metabolize the amino acid tyrosine from phenylalanine. Phenylalanine is an essential amino acid found in foods that contain protein. In lacking of this enzyme, phenylalanine levels accumulate in the body, can damage the central nervous system and causing brain damage because it's toxic. Phenylketonuria has as main characteristic the autosomal recessive genetic inheritance, since the parents are carriers of the defective genes, and when being transferred from both parents, the disease is expressed in the descendants. The treatment consists of administering by means of a diet only the quantity of phenylalanine that is needed for the growth and repair of tissues. The reduction of phenylalanine serves so that in the body the concentration of it is tolerable. BH4 is the essential coenzyme for the conversion reaction of phenylalanine to tyrosine, carried out by the enzyme phenylalanine hydroxylase, or PAH. This activity is deficient in patients with PKU. The results of the test show that patient 1, when administering the BH4, elevates the levels of phenylalanine as the hours pass. Inferred that it is impossible to metabolize the amino acid to convert it to tyrosine, and on the other hand, patient 2 shows that as time goes by, the levels of phenylalanine fall. So as metabolizing and becoming tyrosine. Therefore, it can be deduced that the suspicion of phenylketonuria is there. So the initial step in the metabolism is transforming the phenylalanine to tyrosine, with the tetrahydrobiopterin being the carrier. Phenylketonuria is caused by deficiency of the enzyme phenylalanine hydroxylase. Elevated levels can rarely be caused by deficiency of the cofactor BH4. Tyrosine is seen as non-essential because it is synthesized from phenylalanine in the body. It is not synthesized in cases where there is a deficiency of the hydroxylase, so it would then become essential within phenylketonuria. Some reasons for this could be a defect in the gene that produces phenylalanine hydroxylase. When the phenylketones are elevated, some explanations could be the dihydrobiopterin reductase deficiency and deficiency of tetrahydrobiopterin, so BH4. Both of these can be reason for elevated phenylalanine within the blood. It builds up in tissues and causes seizures, body odor, and mental retardation, as we spoke about before. For the BH4 loading test, it's used to tell apart hyperphenylalaninemia. That is a big one. Patients, since it can be from either the PAH or BH4 deficiency. Although with BH4 deficiency patients, the PAH deficiency is commonly seen as well. In many cases, as a normal treatment, BH4 can be supplemented, and that would work just fine. With patient A, the phenylalanine levels are increasing alongside with BH4 being, so it is most likely because of PAH being absent and deficient. In patient B, the phenylalanine levels decreased dramatically after BH4 was given. So that means that the levels of phenylalanine decreased due to the conversion to tyrosine being adequate. So, given my sources, moving on to case number 3 now. Let's see if I can go back to the case here. Alright, so a 47-year-old man presents with severe pain in his right great toe. He is unable to bear weight on his right foot, and there was no apparent trauma. He reports the pain started last night and continued to increase in severity. Based on his physical exam and laboratory findings, he is diagnosed with gout. Gout can be caused by several different mechanisms, and blood samples are drawn and urinalysis is performed. The results from this individual are listed below. So his plasma urate levels were elevated, and let's see, the urinary uric acid was way under the normal amount. So what is the best explanation for the presentation of gout in this individual? And please explain why the other choices are not consistent. Let's see. The options that were given: overproduction of purines, decreased salvage of purines, and decreased urination excretion of uric acid. I'm going with that one. After further discussion with the patient, he tells you that he recently switched from diet soda to regular soda because he read that the fake sugar diet soda was bad for him. He tells you he drinks between 4 and 5 liters of soda a day. What is the potential impact of this dietary modification on the presentation of gout? So the decreased output of urine has caused the gout since the uric acid was not excreted. And gout is a systemic disease developed due to excess deposition of crystals of monosodium urate in tissues. When the uric acid concentration in serum reaches above a threshold value, then they start forming uric acid crystals. The high majority of gout cases tend to be from not excreting enough uric acid. Overproduction of purines and decreased salvage of purines are not right because only serum levels and uric acid was tested clinically. So in order for those options to be viable, more tests must be observed, like HGPRT, because this type of deficiency leads to an overabundance of uric acid. It is linked to X-linked genetic disorder, so family history could help in determining this factor. Also, a test for over-intake of purine-rich diets would help as well. There are underlying reasons such as inflammation, chemotherapy, and presence of malignancies could be reason too. So previous patient history is extremely important to help determine the underlying reasons to help better diagnose. And obviously the diet plays a huge role. In sugary foods and drinks, fructose causes an increase in uric acid, as well as purine-rich foods such as pork, beef, seafood, all the stuff that we like to eat. So definitely decreased urinary excretion of uric acid. So high plasma uric acid, or UA, is a precipitating factor for gout and renal calculi, as well as a strong risk factor for metabolic syndrome and cardiovascular disease. Main causes for higher plasma UA are either lower excretion, which I believe that's it, higher synthesis, or both. So UA contributes to over 50% of the antioxidant capacity of the blood. It is characterized by a high uric acid level in the blood, causing deposition of uric crystals in the joints and kidneys. In normal humans, uric acid is excreted in the urine. However, uric acid excretion may be impaired by kidney disease, leading to hyperuricemia. Other less common causes are a diet high in purine-containing items, or your body just producing too much uric acid. Excuse me. In people, purines are metabolized into uric acid, which is then excreted in the urine. Consumption of some types of foods, just like the ones we talked about, increases the risk. It doesn't ensure like you're going to get gout, but it increases the risk for it. And some more of those foods are like regular consumption, not just like a one-time deal, but regular consumption of meats, liver, kidney, sweetbreads, certain types of seafood, not all of them, but some examples: sardines, mussels, scallops, trout, tuna. Moderate intake of purine-rich vegetables, however, is not actually associated with risk of increasing the risk of gout. Foods and drinks that often trigger gout attacks include organ meats, game meats, some types of fish, fruit juice, sugary sodas, and alcohol. On the other hand, fruits and vegetables, whole grains, soy products, and low-fat dairy products may help prevent gout attacks by lowering uric acid levels. Drinking too many changes how much uric acid is in the body. So like beer and liquor. And I guess sugary drinks. It's more likely to trigger the first acute gout attack than some other forms of alcohol, like wine, but avoid alcohol, up your vitamin C intake, avoid obviously sugary foods and beverages, and yeah, that's all I got, but I hope that was informative and educational. I sure learned a lot doing this research. So, hope you enjoyed. Thanks for